Good afternoon. I'm here to discuss with you some information from Chapter 22, The Child with a Cardiovascular Alteration. Before we get into any abnormal portions of the heart, we're going to discuss what's normal. First of all, the normal cardiac anatomy and physiology includes the fact that the heart is a muscular pump, and it is divided into 4 chambers. Those chambers are the left atrium, the right atrium, the left ventricle, and the right ventricle. Always remember that the upper portions are the atria, the lower portions are the ventricles. The atria are the actual filling chambers of the heart, and the ventricles are the ones that actually pump the heart, so they're the pumping chambers. The 2 atrioventricular valves, also known as the AV valves, are the tricuspid valve and the mitral valve, and the 2 semilunar valves are the pulmonary valve and the aortic valve. The circulation through the heart is as follows. Deoxygenated blood from the upper and lower body enters the right atrium of the heart. The right ventricle then pumps the blood to the lungs through the pulmonary arteries. Once in the lungs, the blood releases carbon dioxide and absorbs oxygen, which is then returned to the left atrium. The left ventricle pumps oxygenated blood into the aorta, which is then pumped to the rest of the body in order to deliver oxygen. I actually have a handout that you'll be getting that includes how this blood is flowed through the heart and also a picture of the anatomy of the heart. This is it. As you can see, the right ventricle is here, the left ventricle, the left atrium, and the right atrium. In the arrows, you follow the arrows and you can actually see how the blood flows through the heart and where it goes. As you can see, the superior vena cava and the inferior vena cava. The inferior is where blood is received from the lower portion of the body, and the superior is where it's received from the upper portion of the body. And then you can see where it goes to the pulmonary arteries. Just follow the arrows, but I'll be glad to pass this out to everyone after class. The contraction of the heart. The mechanical contraction is actually started with the electrical stimulation by the sinus node. This then spreads through the atrium to the AV node, which is transmitted to the ventricles through the bundle of His and the Purkinje fibers, resulting in the rhythmic atrial electrical stimulation and then the contraction, which is followed by ventricular stimulation and contraction. As you can see, those contractions actually cause the pump to clamp down, which will force the blood out of those chambers into the chambers where they need to be, and then that is actually how the blood is pumped through the body. It's the force of those contractions. When you're talking about children, there is a little difference in the fetal circulation and transitional and neonatal circulation. Transitional meaning from when they're in the womb to when after they're born. This differs in 3 areas from adult circulation. The process of gas exchange is different. The pressures within the systemic and pulmonary circulations, and the existence of anatomic structures that actually exist in the fetus that assist in the delivery of oxygen-rich blood to the baby. Gas exchange takes place at the placenta. Oxygen and nutrients are carried by the blood in the umbilical vein, then to the fetal liver to the inferior vena cava. A small amount of blood does go to the liver to provide oxygen to these tissues as well. There are 3 structures: the ductus venosus, fetal blood. This is a fetal blood vessel that joins the aorta and pulmonary artery. This closes at birth. The foramen ovale, which allows blood to enter the left atrium from the right atrium. It's actually an opening in the middle. This also should close at birth. And then the ductus arteriosus, which shunts some of the blood from the left umbilical vein directly to the inferior vena cava, which allows oxygenated blood from the placenta to bypass the liver. The functional closure of this occurs at birth, meaning it quits doing this at birth, which is what it's supposed to do, but the actual closure, the structural closure, occurs within a week of birth. Common diagnostic testing for cardiac disease or disorders include the electrocardiogram. What this does is this is the actual recording of the heart's electrical activity from outside the body. It measures the P wave, the QRS complex, and the T wave. And what those are, the P wave is actually the atrial depolarization, the QRS complex is the ventricular depolarization, and the T wave is the ventricular depolarization. Now, I'm going to show you a picture. This is a small snippet of an EKG strip. As you can see, the P wave occurs first, and this would be a normal rhythm strip. The P wave occurs first, then you have your QRS complex, which will then go into your T wave. As you can see, here's your PR interval. Here's your QRS interval. Here is your QT interval and your ST. ST interval is really indicative of a lot of heart failure. There's a lot of changes that occur here. Okay, next we have a Holter monitor, which is a continuous recording of the heart. It typically lasts about 24 hours. It's worn throughout the day. You actually have a button you can push if you feel any of the cardiac events occurring. If you feel a little flutter, of course that's harder on babies, so they have to rely on the information gathered when it's small children. The chest x-ray, which is just an x-ray of the heart and the organs within the chest cavity to determine, to ensure that everything's there like it's supposed to be and everything looks good. Echocardiography, which is a high-frequency sound wave. It actually uses ultrasound waves that are used to generate image of the heart and the associated structures. What an echo can do is it can measure the pressure within the valves. It can see that the valves are working correctly. And then you have an MRI, which allows visualization of the soft tissues, tumors, shunts, myocardial thickness, structure, and the valve function. But of course, some of those can be measured as well during an echocardiogram. A ventilation perfusion scan, also known as a VQ scan, uses intravenous isotopes to measure the distribution of pulmonary blood flow and ventilation, which is shown for assistance in quantifying percentage and pattern of pulmonary blood flow. The ventilation perfusion scan is very important with the lungs and the blood in the lungs. Pulse oximetry measures the O2 saturation of blood through the probe attached to the finger, and I actually have one right here. This is what measures your pulse ox. As you can see, you turn it on, very easy to use. You're able to stick your finger in. This works for anybody of any age and will actually measure. It may take a little bit, so we're not going to actually do that right now. But as you can see, it'll actually measure that there's a beat, and it picks it up, and then it'll actually measure the amount. And right now, mine is 97%, and my heart rate's 81. This actually gives you the percent of oxygen within your blood. Okay, now we're going to discuss some congenital heart diseases. Most frequently seen congenital heart defects in children are, the incidence is 8 out of every 1,000 live births. More adults are living longer and longer with congenital heart disease. And congenital meaning you're born with it. It's things that happen at birth or before birth that do not resolve. The prevalence of congenital heart disease in adults is 4 to every 1,000. Non-genetic etiology and risk factors are not fully known. They don't know why these happen. But they can include maternal diabetes, maternal infection during pregnancy, maternal smoking, maternal obesity, and maternal exposure to chemicals or pollutants that are unknown, but these things have been implicated in that. Children with certain genetic conditions or defects have a high incidence of cardiac disorders. And this includes children who have chromosome abnormalities, most specifically trisomy 21, which is also known as Down syndrome. Other congenital conditions increase the risk for congenital heart disease include Turner syndrome in girls, which is a single X chromosome, Klinefelter variant in boys, which is genetically having an additional X chromosomes. Children with Marfan syndrome who have abnormally long limbs is one of the ways that you can identify that. Usually Marfan syndrome is not diagnosed until they're a little bit older and they're going through puberty. And then also the family history of congenital heart disease increases the risk for children. There are several classifications of congenital heart disease, and they are classified according to the structural abnormalities, the functional alterations, or both. Left to right shunting lesions, that is a defect in the atrial septum or persistence of a patent ductus arteriosus, also known as a PDA. It causes saturated blood to shunt through the opening, results in volume overload in right side of the heart and pulmonary artery. It increases the cardiac workload, which leads to heart failure, pulmonary hypertension, and respiratory failure due to numerous respiratory infections. Examples of these are atrial septal defects, ventral septal defects, patent ductus arteriosus, and endocardial Cushion defect. Okay, another classification of congenital heart disease is an obstructive or stenotic lesions, or lesions that decrease cardiac outflow, which include narrowing or constricting of an opening which is in a valve. It can cause obstruction of blood flow. Pressure rises behind the valve obstructed. Blood flow on the distal side becomes absent or decreased. Causes increased cardiac workload leading to heart failure again, decreased cardiac output, and pump failure. Examples include pulmonary stenosis, aortic stenosis. Another one is a cyanotic lesion with decreased pulmonary blood flow. These are caused by fatal error in fetal development that results in incomplete development, hypoplasia, malalignment, or obstruction of the right side of the heart, and decreased blood volume to the lungs. An example of this is tetralogy of Fallot, which are the three tricuspid valve abnormalities, pulmonary atresia with intact ventricular septum, and the next type is a cyanotic lesion with increased pulmonary blood flow, failure of the fetal heart to separate pulmonary and systemic circulations, or when a reversal of circulation occurs, so oxygen blood goes to the pulmonary system and blood without oxygen goes to the systemic system, which, as you know, is opposite. This causes increased cardiac workload, ventricular strain, and decreased cardiac output. Intervention may be required to support life, because if your body is not getting the oxygen it needs, your brain is not getting the oxygen it needs, life cannot be sustained. Examples of these: transposition of the great arteries in which they're swapped, hypoplastic left heart syndrome. There are a few blood flow and shunting considerations. Blood flow should be 1-to-1. Same amount of blood flows to the lungs through the pulmonary artery is the same as the blood flow through the aorta to the systemic circulation. The shunt is abnormal blood flow from one part of the circulatory system to another. Shunts occur when a shunt can occur, and that occurs when there is an abnormal opening or connection between the chambers or the great arteries. The pressure is higher on one side of the heart than the other, compared to the other, and the oxygen saturation is increased or decreased in normal, desaturated, or fully saturated blood. If it happens on the venous side, which is the right, normal low pressure occurs and blood is desaturated. If it occurs on the left side, which is the arterial, pressure is usually high and blood is saturated. Some physiological consequences of congenital heart disease in children. Number one is heart failure. Heart failure is where the heart isn't unable to circulate blood to maintain sufficient cardiac output to meet the metabolic needs of the family of the body. You just can't pump enough blood, so therefore your tissues don't get oxygen. The body actually begins to die. Cardiomegaly, which is an enlarged heart. It's caused by overworking of the heart, which then in turn leads to heart failure, because as the heart is overworking and it's working too much, it's going to get bigger because the heart is a muscle, which will eventually lead to heart failure because it can't sustain that size and can't sustain that pumping ability to pump to the entire body. And pulmonary edema, which is congestion in the body and or lungs caused by poor cardiac function. Pulmonary edema can be caused, is the result of the body not being able to clear out those tissues and because the blood isn't circulating correctly through there. The etiology is different in adults, usually congenital in neonates, infants, and children. Heart failure can occur over time in adults, but in children, when you see it, it's usually congenital. Acquired heart disease can be something related to something caused by cardiomyopathy, arrhythmia, infections such as endocarditis, myocarditis, pericarditis, and tumors. Damage to the heart can occur at any time, can be from resulting from metabolic disorder, exposure to certain drugs or toxins, and then arrhythmias. Any abnormal beat that disrupts the balance of the electrical or conduction system of the heart. At first, it may not seem that important, but over time, as it gets more and more common, it can lead to poor cardiac output. Manifestations of heart failure usually is very subtle. The infant may have mild tachypnea at rest and difficulty feeding, longer feeding time where the child requires rest, which leads to poor nutritional intake, resulting in failure to thrive. The respiratory-related symptoms include dyspnea and tachypnea, less energetic than their peers. They exhibit diaphoresis and decreased appetite. Chronic abdominal pain may be a complaint. Clinical manifestations of heart failure include abnormal rhythm known as a gallop that can actually be heard, periorbital and facial edema, neck vein distension right through here. You'll actually see this, especially in older children. Their liver can be enlarged, their spleen can be enlarged, decreased perfusion in the peripheral areas, decreased urine output because their body's not it's not cleansing the body and produced, so they're actually having fluid accumulation, so therefore their urine output is decreased. Mottling, cyanosis, or pallor. In order to diagnose this, the diagnostic evaluation will include a clinical history, physical examination, medical testing such as chest x-ray, EKG, and of course an echo. And the lab studies that could be include an ABG, which is an arterial blood gas to determine the oxygen, and the other things, is the person, is their blood mildly acidic, are they, that type thing. Electrolyte levels such as a BNP or a CMP, a CBC, a sed rate, glucose, calcium, and also possibly a urinalysis. The therapeutic management for heart failure includes correcting the underlying problem as soon as possible, if it is feasible to do so, and you can use medication to treat heart failure as well. Digoxin, diuretics, and ACE inhibitors. Before beginning DIG use, you always obtain a baseline EKG. If it's given IV or orally, you always do a loading dose based on the weight. And then the therapeutic range, which is monitored through blood test, is 0.5 to 2, which is measured 6 hours from the previous dose. So if you give it at 8 o'clock in the morning, you would not want to check their DIG levels until after 2 in the afternoon. You have to be aware of arrhythmias. That is included in the teaching for the parents of the children who are on this. If you notice any arrhythmias while on digoxin, you would immediately check the DIG level. DIG use increases the risk of hypokalemia and hypomagnesemia, so you would always check that with a CMP or a BNP. You would always want to check their potassium and their magnesium. Decreased dose of DIG for a child with a renal impairment. So those are a few of the things that can happen with heart failure. We just touched the surface of the congenital problems for children, so I hope you stay tuned for our next lesson as we'll delve a little deeper into these. Thank you. Have a good day.